We continue with our intestinal pathology, both the small and large intestine, with intestinal ischemia, and then we're going to continue on to a few other miscellaneous pathologies. So intestinal ischemia, there's many different etiologies, and they have different names. So we're going to cover a few of them. We're going to cover acute mesenteric ischemia, cover chronic mesenteric ischemia, and finally colonic ischemia. So first, acute mesenteric ischemia. This results from an embolus or thrombosis. So a blood clot is an embolus traveling all the way to the intestinal vessels, or thrombosis, where just clots, locally clots. And this is going to lead to an acute critical blockage of intestinal blood flow. So it's a sudden change. And what does this sound like? What other syndromes does this sound like in other parts of the body? This is pretty much the same thing that goes on in an acute coronary syndrome. For example, NSTEMI, STEMI, unstable angina. It's the same thing that's going on. You have embolism or thrombosis leading to acute critical blockage. And so what happens is this blockage is going to lead to ischemia, because blood's not going to be able to pass. You're going to get small bowel necrosis. And what you're going to see is you're going to see an abdominal pain out of proportion to the physical findings. Now what the heck does that mean? It means that on abdominal exam, the patient may have a normal exam. They may have a soft feeling abdomen. They might no guarding or rebound, but they're going to be screaming in pain. So you're like, what the heck? Why are they screaming in pain? That doesn't make sense. But it might be because they have acute mesenteric ischemia. Okay, the other thing you could see is a red currant jelly stool. So the red is from the blood, because you have necrosis, and then there's going to be bleeding as your cells die and your blood vessels also die and blood comes out. And then the currant jellies comes from that mucus that's in your intestines. This problem most commonly affects the SMA, the superior mesenteric artery, which supplies the midgut. So that's from the duodenum up to 2/3 of the transverse colon. Okay, and that's because of just anatomic factors. Okay, so remember, what vessel? It's the SMA. And what did the SMA supply again? I just said duodenum all the way to 2/3 of the transverse colon. So now we're going to go to chronic mesenteric ischemia. And this is basically angina of the mesenteric arteries. Angina arising from atherosclerosis in any of those arteries, in the celiac, superior mesenteric artery, or the inferior mesenteric artery. Atherosclerosis blocks blood flow. Intestines are not getting enough blood flow, and so you can get this chronic mesenteric ischemia. And commonly what patients will have is they'll have pain after eating. And the theory here is that eating will shunt blood to the stomach. So there's less blood going to the intestine, more blood going to the stomach. And so now you're further compromising intestinal perfusion, and that's why the patient's going to feel pain. So finally we have colonic ischemia. I know that lots of different names, very confusing. Colonic ischemia here is ischemia, and it arises from non-obstructive hypoperfusion of the colon. So these first two were from obstruction. There's embolus or thrombosis obstructing, there's atherosclerosis obstructing. This is due to hypoperfusion. For example, if a person is bleeding out, they lost their arm or something, they're bleeding out, not much blood is going to go to the colon. And so then there's going to be ischemia. And the most commonly affected areas are the watershed areas. That would be the splenic flexure right here. This is where the spleen is on the left side. And this is the distal colon. And these are called watershed areas because these are the area, basically the no man's land. They're like in the out in the boonies out here that's barely getting any blood perfusion. Okay, it's like the boonies has like terrible internet. Okay, because there's terrible wiring. These watershed areas have terrible wiring of the blood vessels. So you get the most distal stuff. So when there's shortage of blood, these guys are going to be the guys that are going to be missing blood first. Splenic flexure, distal colon, okay? Now symptoms here are you're going to get crampy abdominal pain and bloody diarrhea. Again, it's because due to the ischemia, necrosis, bloody diarrhea, crampy abdominal pain. So again, all these intestinal ischemia types, acute is basically the heart attack of intestinal ischemia. Chronic mesenteric ischemia is basically angina of mesenteric arteries, and the colonic ischemia arises from hypoperfusion. It affects the watershed areas. Simple as that. Next is angiodysplasia. Angio refers to blood vessels. Dysplasia means abnormal. It's not right. So there's abnormalities of the blood vessels in the GI tract. So we can just look at the name, you already know. And there's abnormalities, as you can see here, that looks like it could bleed pretty easily, okay? And that's true. It's susceptibility to bleeding. And these abnormalities usually arise from degeneration, okay? So the presentation here, degeneration occurs as you grow older, you get degeneration. And then because these are susceptible to bleeding, what you're going to see is hematochezia, which is blood in your stool. Okay, so very simple. Angiodysplasia from degeneration tells you all you need to know. Because what is it gonna tell you? It's gonna tell you it's abnormalities of blood vessels. It's gonna be easier bleeding. It's gonna be in older patients. You're gonna be bleeding in your stool in older patients in angiodysplasia. All right. Next is adhesions. What is an adhesion? It's this stuff. Okay, this stuff right here. This stuff. This stuff. This stuff. And it adheses your abdominal organs to other stuff. For example, to the abdominal wall. You can have adhesion between abdominal organs. Between, example, the intestine and the liver, intestine and the pancreas, blah, blah, blah. These are basically fibrous scar tissue. And they often develop after abdominal surgery. So what are we doing in surgery? We're just cutting everything out, right? We're basically stabbing the patient. What happens after you get cut? You get scar tissue. So you're going to get all this fibrous scar tissue, subsequent scarring, fibrous scar tissue between different abdominal organs. And this scar tissue can wrap around and cause obstruction. So this is actually the most common cause of small bowel obstruction. You have all these fibrous stuff, and you can imagine that they can basically lead to obstruction of your small intestines. So that's adhesions. Finally, ileus. I've probably heard of ileus already. Ileus basically means intestinal hypomotility. That means your intestines aren't moving along, so your food's not moving through the GI tract. And often you see this after abdominal surgery or opioid use that will lead to hypomotility of the intestines. What clinical features would you see if you have hypomotility? Are you going to have diarrhea or are you going to have constipation? You're going to have constipation because your food's not coming out. Your poop's not coming out. You're also going to have distended abdomen because if the food's not coming out, where is it going to be? It's just sitting in your abdomen. It's going to build up. It's distended. And the other thing is, there going to be gas or not. There's going to be decreased gas. Again, it's just hypomotility. It's all that comes from the hypomotility. Very easy. Now the treatment here, which is low yield for step 1, but it's very high yield for surgery, because again, you see this after abdominal surgeries. What you do is you give them bowel rest. So you first make sure they're not nauseous. You don't give them anything. Don't let them eat anything. Just give them IV fluids until they're not nauseous and until they're not vomiting. Then you start giving them a little bit of fluid, a little bit of liquids. If they're tolerating liquids, they're not having nausea or vomiting, then you can advance their diet. That's what we call it. You advance their diet from liquids to solids. You start with soft solids and you get to more solid stuff. And you just keep going. You go a little bit at a time and just make sure that they're not nauseous or vomiting. Other thing we can do is we give them laxatives, helps them poop. And then, of course, you can avoid opioids as much as possible. There's other drugs that we can give them that are not as open, that don't cause as much intestinal hypomotility for their pain control. So that is it for for the intestinal ischemia, as well as some other miscellaneous intestinal pathologies.